Dear colleagues, this is an intumescent cataract, and in this case I am going to demonstrate my technique of capsulorhexis. In my technique, I don't use any costly viscoelastic substance. I use only 2% HPMC, which is very economical. By this time, a main incision and two side port incisions have been made. An air bubble has been injected into the antechamber, and now trypan blue dye is injected into the antechamber to stain the anterior capsule of the cataract. Now the dye is washed out with a Simcoe cannula. Next is to inject viscoelastic substance, and as I said, I use only 2% HPMC. Here it goes, 2% hydroxypropyl methyl cellulose. Now I incise the center of the anterior capsule with a bent cystitome. Here it goes, and this incision is a curved one like C, and I've seen with this incision it doesn't tend to extend to the periphery. Now I take a utrata forceps and do a very small rhexis like this. It is a MiniRhexis. It takes very little time. Even if some amount of viscoelastic substance leaks out through the main incision, I can complete this. Now the intralenticular pressure is decreased in this way. Some superficial lens matter is aspirated with a direct Simcoe cannula. This can be done with a bimanual IA also. We have two side ports. Instead of this Simcoe cannula, one can use bimanual IA and aspirate some superficial lens fibers. Now 2% HPMC is injected again. The chamber is deep now. Now a Vanna scissor is used to cut the margin of this MiniRhexis. Utrata forceps is again taken. This is enlarged. Now the MiniRhexis is enlarged with this utrata forceps. That's it. So we have enlarged the MiniRhexis, and this is an optimum sized rhexis now. Now the tip of the phaco handpiece is introduced into the antechamber. This is grade 3 or grade 3 plus nuclear sclerosis, and I do direct chop in such cases. And this chopper is a micro chopper. It is just little stouter than Sinskey hook, and it is universal. I can do vertical chop as well as horizontal chop with this one. At this time the phaco power is 65%, flow rate is 45 ml per minute, and vacuum is 450 millimeter of mercury. So the nucleus is almost managed. So far we are going very well. The last nuclear fragment has just now been removed. While I remove the last fragment, I take the chopper out so that there is no leakage from the side port, and the fluid pressure sends the posterior capsule backward. Again visco is injected into the antechamber, and now I use a Simcoe cannula to do cortical cleanup. It doesn't matter what you use. What matter is this cortical fibers should be cleaned nicely. One can use a bimanual IA, one can use a coaxial IA, one can use a Simcoe cannula. The thing is, this cortical fibers should be nicely cleaned. That's it. The cortical fibers are cleaned, the posterior capsule is clear, and now we are going to implant an intraocular lens, in this case under irrigation. This is a hydrophilic acrylic intraocular lens. So the lens is implanted, it is dialed, and that's it. The surgery is over. The side ports are hydrated to make the side ports watertight. And now this is the final wash under higher magnification. I can see the visco material. Here it is. We can see the visco molecules even with this higher magnification, visco strands. And this is a nice cleanup. This is anterior chamber is formed. Thank you very much for watching.